Yeah, we do have a small meeting here today, but I'm just supposed to give a quick introduction. We are here with the Interagency Arctic Research Policy Committee, and that's a group of 16 federal agencies along with our local health partners, ANTHC, Alaska Native Tribal Health Consortium, State of Alaska, university researchers. So IARPC, we're charged with promoting health and research through collaborations. So today, this is a meeting of the Health and Wellbeing Collaboration Team. And we do have over 250 members, but I think we're having a little bit of a low bandwidth with COVID. And the Health and Wellbeing Collaboration Team, we're towards the end of a 5-year plan, which goes from 2017 through 2021. And it's a 5-year research plan about the Arctic. And so the health and well-being team has a sort of mix. We operate sort of around performance elements, and we have a mix of different performance elements. We're looking at research on zoonotic diseases, at indoor-outdoor air quality. We have some performance elements around water and sanitation, as well as importantly with climate change. We have performance elements around mental health and resilience as well. But one of our performance elements is on telehealth, so sort of promoting federal agencies helping to promote research on the use of telehealth in remote rural Alaska. And so that is, I think it's performance element 1.7. And so we're sort of here to talk about that today. And we're lucky enough to have, well, we were going to have 2 ANTHC researchers, but we have Dr. Liz Ferucci with us today, who sort of wears 2 hats. She's both a clinician and a health researcher at the Alaska Native Tribal Health Consortium. She's, I believe, a rheumatologist by training and a MD, MPH, and she has a lot of experience sort of delivering healthcare for chronic diseases in rural Alaska, and does field clinics, as well as has had studies addressing the use of telehealth in chronic diseases. So I want to really thank you for joining us today, Liz, and I'm going to turn it over to you for your presentation.
Thank you so much, and I'm going to get it shared here. But yes, absolutely, I am a rheumatologist at the Alaska Native Tribal Health Consortium here in Anchorage. The presentation that I'll give you today is really focused on, I'll give a little bit of background, but it's focused on kind of our ongoing research project related to, the title of the research project is Evaluation of Telemedicine for Chronic Disease Specialty Care in the Alaska Tribal Health System. And so I am a rheumatologist, but I'll be talking about chronic disease in a little bit more of a broader perspective here. And I just have a relatively short presentation. There's a lot that kind of goes into developing this project, and you may have questions about things beyond what I have in here. And I'm happy to stay on as long as needed to answer questions, either during the talk or at the end. This is just kind of the outline of what I do have put together today. I was going to start with just some background about how specialty care is delivered in the Alaska Tribal Health System, a little bit of background on telehealth, past, present, and maybe future. And then I'll talk about our ongoing research study, including our 3 specific aims, the different methods that we're using for these, and a little bit of preliminary results. And then I'll go on to sort of the future. What do we see changing after the pandemic, and how are we planning to analyze that with this study, and maybe some thoughts about future studies that might be useful. So all of you here, I believe, are familiar with the Alaska Tribal Health System, but just as some background, it's an affiliation of tribes and tribal health organizations that provide health services statewide to Alaska Native people. And it's not as much of a it's sort of a loose affiliation in some sense, but so each region is somewhat different, which makes it sort of challenging in some senses. But the Alaska Native Medical Center in Anchorage provides tertiary care statewide. So it provides specialty services to all the regional tribes and tribal health organizations throughout the state. With some exceptions, actually, some supplementation at the regional level as well. But in general, this is the tertiary care hospital for the state. As far as specialty care in the Alaska Tribal Health System, the example that I work in is rheumatology. So this is our example, but it really applies to most specialties at the Alaska Native Medical Center. So we all have our specialists sort of based, I'm gonna see if I can, our specialists based here in Anchorage, and then at the main hospital. And then we do hospital-based clinics in Anchorage. So if a patient needs to see a specialist, they can come into Anchorage, or if they live in Anchorage, they can come and get seen here. We do field clinics, and for rheumatology, we have a pretty extensive network of field clinics. Not all clinics do as many of these, and some specialists don't do field clinics, just if they're a short supply or they really are needed to be in Anchorage more often. But for us, the green represents all the locations where we go for field clinics. This ends up being, at the moment, we have a total of 32 clinics per year, divided between 4 rheumatologists, so it's quite a few. They're typically, on average, about 3 days twice a year. So we try to get as many patients from the region in to be seen during those field clinics as possible. But as you can imagine, not everybody gets in every time that they need to. And so we supplement that also with telehealth, which we've really been doing kind of in a broad sense in the Alaska Tribal Health System for the specialty care since about 2015. Although there were some other things available prior to that as well. So these are, the ways that we get out to deliver care, and we have a lot of different options that keep expanding over time. The history of telehealth, so it actually has been available through ANTHC and the Alaska Tribal Health System since about the year 1999 or 2000, when the store and forward consults, or the AFCAN system, was developed. And it was developed to kind of get around the issue of internet bandwidth and connectivity, so that these carts were deployed to the village clinics. They were often used in ENT, post-ear surgery. The health aide in the local clinic would take a picture of the eardrum and send that to the ENT provider so that the patient would not have to come in. And there were actually some extensive research studies done early on determining that the accuracy of the telehealth consult, the store and forward consult at that time, otherwise known as asynchronous telehealth. So that was used quite extensively for quite a few years. And then on the right, we see the live video visits. That's Dr. Schnellbacher in cardiology clinic. Cardiology was really the first specialty clinic to broadly adopt telehealth live video visits for their follow-up patients, which is why we show them as the example. So they started around 2012, and then really things started to expand after that. And in 2015, like I mentioned, it was broadly adopted for more specialty clinics. When we talk about live video visits in the Alaska Tribal Health System, there's the option of the patient being in a clinic locally and connecting over the video from the clinic with a health aide or some other presenter present. There's also more recently the option for direct to patient home or mobile device visits. Those were very, very limited in our system until the pandemic hit, and then those have been expanded quite a bit. But that one, of course, depends on the patient living in an area where they have adequate connectivity at their home or a location that they can go. So we still do quite a bit of clinic to clinic, but the direct to patient live video visits have increased recently as well. So a little background on this research project. So we actually I had a medical student that worked with me one summer, and we did a qualitative study looking at patient and provider perspectives on the use of telehealth live video visits. So that right-hand side of that previous slide, and mostly that was clinic to clinic at the time. What were the benefits and barriers of telehealth? And medical student Nikki Jordan worked with me over a summer. We did some in-depth interviews with patients and providers. And as you can imagine, the big plus to telemedicine was avoiding travel, saving money, being able to see a provider more often. And then one thing that people, that comes up as a theme for us is improved communication. And that can be patient to provider. It can also be provider to provider if there's a presenter on the local clinic and like a health aide that needs to be involved in the care. So those were the big pluses.
I'm sorry to interrupt, but there's a couple things. One, we just had a 907 number join ending in 896. Could you let me know who you are?
Hi, it's Brian McMahon. Can you hear me?
Yes, we can hear you.
Okay, sorry, I could not get on. I had no idea how to connect. Every time I tried, they wanted a password, and I didn't know which passcode and to put in, and so I finally dialed in.
Okay, I can work with you on that behind the scenes here, and I'll just let Liz go forward.
Okay, if you want to just email me at bmcmahon at anthc.org, and then give me the connection, and if there's a password, I can hook in.
Okay.
Okay, so then, so this was our previous qualitative study again, and the disadvantages of telemedicine from the patient and the provider perspective are kind of summarized together here on the slide, but disadvantages were not being able to do a physical exam. Patients were more concerned about the privacy issues. Providers sometimes mention technical difficulties and the need for a trained presenter. And then also this complexity of scheduling. When we were doing the clinic to clinic visits, it needs to be confirmed with the patient and both clinics that the time of the visit will work for connection. So those were kind of some of the limitations from what we had seen before. The other thing kind of guiding this work is I had started with rheumatoid arthritis because I'm a rheumatologist, and that was the thing that we see most often. And so I had a study funded by Agency for Healthcare Research and Quality, who fund this current study I'm about to mention, as an R21, looking at rheumatoid arthritis specifically. And we were looking at telehealth for follow-up of rheumatoid arthritis. It was an observational study, just looking at who chose to use telehealth versus did not when it was offered as part of usual care, and what were the outcomes. And so what we found from that study was telehealth was more likely to be used for people who had more active arthritis. When the patients had more favorable opinions of it, we had a telehealth perception survey as part of that. And then when the physician used telemedicine more often. So these all seem somewhat obvious. And then there was no clear difference in disease activity or quality of care when you compared people who had ever had telehealth visits versus in-person only. But this was a pretty short-term study and relatively small numbers. We did think that being able to see people more often would probably improve long-term disease outcomes, but that study wasn't really designed to look at that. And so as we went to design a larger study, I worked closely with Sarah Freeman, who was at the time with ANTHC Telehealth, to look at how is telehealth being used in the Alaska Tribal Health System for a broader set of chronic diseases. And so ultimately we put together a grant looking at 3 specific aims. This was funded by Agency for Healthcare Research and Quality, or ARC, as an R01 grant starting April 1st, 2019. So we've actually just started year 3 of 5 total years. And this is looking at a broad set of chronic diseases that need specialty care in the Alaska Tribal Health System. And so we have 3 aims. One is looking at predictors of receiving care by video telemedicine, because this is all being done observationally in the setting of usual care. that aim is important, but it's also very important to know what those are when we're adjusting the analyses for aims 2 and 3. Because in aim 2, we want to look at the relationship between having telemedicine visits and clinical outcomes of chronic disease. And so we need to know what things are important to adjust for in these analyses. And then finally, the aim 3 focuses on a cost comparison from 2 different perspectives, which I'll mention in a minute. So this is currently ongoing. I'll say a little bit more about the methods for the different aims. So aim 1, I mentioned, is really predictors. We are using mixed methods for that. That includes qualitative and quantitative data. And we used administrative data from Cerner, the electronic health record, to look at of those who had ever used telemedicine versus never used telemedicine, what were the differences in the demographics and the clinical characteristics that we could obtain from the electronic health record. We also did focus groups with patients, and we did patient and provider surveys and kind of a broader set of patients. And we have, I'll show you just a little bit of preliminary data from this one. We've put together 2 manuscripts that have been submitted to a journal and are waiting to hear back on those, but I'll show you a little bit of that. Of note, on the right, we are planning propensity score matching analysis for aims 2 and 3. So that's why the administrative data is so important. But we also wanted to have a little bit more of the qualitative data because administrative data doesn't always tell you the whole story. And so we wanted to know a little bit more about the story about why people use telemedicine or not. We had actually designed this study, and I think it was actually based on the feedback from one of the reviewers that said towards the end of the study, you should look at whether things have changed. And we actually thought, well, things probably aren't going to change that much in about 4 years or something. But this actually started in 2019. We collected all the data for aim 1 prior to the pandemic. So we had completed data collection prior to March 2020 for these 2 manuscripts that we've put together now. So things have changed quite a bit. And I did not expect that, but this was designed, just perfectly as far as the timing to be able to reevaluate these predictors. And so we will be looking at this again, not this coming grant year, but the next year, starting there to look at what changes are there. The other thing is we've focused on live video visits, and we had, for the most part, that was clinic to clinic visits at the time that we designed it, but we certainly do plan to look at direct to patient visits, clinic to clinic visits. Are they similar? Are they different as far as some of these things, if possible, depending on numbers at that time? So, I'm echoing. Oh, there we go. Okay. So looking at some of the preliminary data we found from the electronic health record, and again, our set is people who have a chronic disease, who have seen a specialist for that chronic disease, who have used telemedicine versus who have never used telemedicine. And again, this data collection was prior to the pandemic. And so just showing you one little snippet of this paper, which was this simple multivariate model looking at factors associated with telemedicine use. And the things that we found was increasing age was more likely to be associated with telemedicine use. I think a lot of people think that, or previously thought that only young people wanted to use it. But as people get older, they have more chronic conditions. So it looks like it's sort of, even when you adjust for some of those things, increasing age was more associated with telemedicine. In this case, we found men were more likely to use telemedicine than women. We thought that might be partly driven by the types of conditions that they had because cardiology was using it a lot, but we did control for that, and men were still somewhat more likely to use telemedicine. We had 4 regions involved in the study, and I'm not naming the regions because I didn't get their permission to name them, but there were certainly basically differences by region, with one being a lot lower and the others being higher in the likelihood of using telemedicine. And that's, for a variety of reasons. And then the number of outpatient visits per year and having any visit to cardiology clinic was the strongest predictor of using telemedicine. And again, these are using telemedicine in the Alaska Tribal Health System prior to COVID-19 pandemic. So these will change, but that was the status as of the time that we're analyzing the data. We've been working with Peter Hulk as our statistician, and he did some really cool things that I just thought I'd show one of his diagrams, which is looking at what are the most common clinics visited in general for specialty disease, where the size of these circles being bigger means the clinics visited more often. And that's either in person or telemedicine. So cardiology was a high user of telemedicine, orthopedics was not, but they both are showing up as kind of very large number of visits. The width of the lines are actually overlap between patients having visits to both clinics in that pair. So the wider the line, the more overlap. And then the color gradient, the pink are the high users of telemedicine in the overlap between the clinics. So this was just a little, I mean, cardiology really stands out as being a driver of telemedicine use, but this was a nice way to look at it, how it overlapped as well. Moving into the patient survey, and I won't, on the left is really small. I don't expect you to read through all that, but we did a survey of patients and we divided them into people who had ever used telemedicine versus never. And we overall found similar demographics, overall health and health literacy in both groups. We actually, as far as comfort with new technology, that was not associated with, it was actually the opposite association that we thought. The people who had never used telemedicine were more comfortable with new technology. And again, that might be somewhat of an age thing. We didn't adjust that one at this point. And then overall, about 60% were saying it works well overall. Most of the people who had never used telemedicine had never been offered it, and many of them were open to it if it was offered. So we will see, like as we've seen in the pandemic, people have been offered it a lot more, and a lot more of them are accepting them. So that was good. And then overall, we asked people if it was okay to use telemedicine for a new condition or to meet a new provider. And the patients said kind of half and half. It was somewhat acceptable. Whereas the providers, I'll show you later, really prefer it for follow-up. So here's the provider survey. We had just 29 providers complete our survey. And that was, we weren't aiming for more than that, but they were more likely than patients to be comfortable with new technology. Of course, they have to work with that all the time. They were similar to patients in their view of how well it works overall, like around 60% said it was well or very well. And then most of them did prefer to use it for the follow-up phase of care, as opposed to the patients who were a little bit more open to using it for new conditions or new providers. We also asked kind of best uses, deciding factors, patient and clinic related for use of telemedicine. And we heard a lot of the same things we had heard from our previous kind of qualitative interview study, that if you don't need a physical exam every single time, then it works better. If they're chronic diseases and you need education and ongoing management, this is great, and so forth. Patient preference is important as a deciding factor, but there's also things about how hard it is for them to travel, where their community is, and then also about when we were doing the clinic to clinic, there's a lot of clinic related factors that play a role as far as comfort with telemedicine at the local clinic and technology and what's available there. So those were very similar to kind of what we had heard in our interviews from previous study. Patient focus groups, I'm just showing a couple of highlights of quotes, but we did separate focus groups for telemedicine ever users versus never users, and we asked them a variety of questions, even if they'd never used it. What did they know about it? Why did they think people might use it? Why did they think people might not? And in some cases, we heard kind of similar things from both groups. Overall, avoiding travel was the biggest benefit. And this quote on the left actually has more than one thing in it. It's sort of about being hard to get around the state of Alaska, but it's also about some people have a harder time traveling than others because of their physical limitations. And it makes it really hard for them to come into Anchorage if they needed to see a doctor. So we heard a lot of that. And then on the right is just a quote from somebody who really did favor using it for the follow-up phase of care because they had already met their provider. And so once they knew them, they felt a little bit more comfortable. That's something in 2013, Vanessa Haratzika and team published a paper about Alaska Native and Native Hawaiian opinions about telehealth for diabetes care. And at that time, they weren't using it very much at all. But people had said sort of the exact same thing. They wanted to develop relationships, and then they would probably be comfortable using it afterwards. So that's been a kind of a common theme. I mean, that's one thing that in the pandemic we're having to be more flexible about, and so it'll be interesting to see how that changes over time as people have more experience with it for new providers and new conditions. And then our second aim is looking at outcomes of chronic diseases from telehealth. We'll be looking at administrative data from the electronic health record using propensity score analysis, using the measures that I described for aim 1, our predictors. And then we're doing also just some direct data collection from patients by surveys, general health, and then some disease-specific measures looking at rheumatoid arthritis and heart failure. And then we're doing some medical record reviews for quality of care. And in this one, we were planning to also repeat data collection in the future of this study. So what are we doing next? Again, I mentioned we'll be repeating the data collection, looking at changes in predictors over time. We'll finish up what we're doing for the outcomes and repeat the data collection for that one as well. And then I didn't really mention cost because we haven't started on that, but we will be starting that this year. And we're looking at the payer perspective with a plan to use Medicaid data, as well as use a tribal health organization perspective of costs associated with telehealth. So I've said a lot about how things have changed with the pandemic. And so as you know, it became more difficult to have in-person visits and to travel and all those things because of the risk of infection. There's been a dramatic increase in telehealth use and with more of the direct to patient, as I had mentioned. And so our questions will be, again, changes in who uses telemedicine, changes in the perceptions around it, when it is best used and things like that will change. We expect to see more direct to patient, and what will that look like? And then there probably will be changes in costs as well as outcomes. So with that, I will end there. And this grant is acknowledged here, as well as our study team on the right. The two with the asterisks next to them were involved in study design, but are no longer with our team because of moving to other organizations. But I wanted to highlight their contribution as well. So thank you.
Thank you. Oh, that is fascinating, and such a a timely thing to have this grant that goes pre-pandemic through the pandemic, and then that you'll have some opportunity, I think, post-pandemic. So did anybody have any quick questions for Dr. Farrucci? We just have a couple other people on the line. Okay, I see Catherine has her hand up. If you want to go ahead.
I'm going to stop my video because of bandwidth issues. I'm a pathologist and transfusion medicine physician, so have a little bit of familiarity with some of the things that you spoke about, Liz. I have two questions. The first is about elderly patients with cognitive impairment, and the second is about lupus patients, which you didn't talk about. My question with the elderly patient is, did you notice any difference in your ability to communicate with elderly patients who have some degree of cognitive impairment over telehealth versus in person? Was it the same, easier, harder? How did that go?
Yeah, so I mean, I can comment on my clinical experience. That hasn't been a specific focus of our study or our focus groups, although I will say patients in the focus groups actually brought up elders in a couple different ways. One way that they brought it up is that elders might have more difficulty traveling, so they might actually appreciate telemedicine more. But some people brought up that elders might have some more issues with it as well. I think the biggest thing from a clinical standpoint is people with hearing loss have a real hard time. So when I've done these, like to other field clinics, a lot of times there's a nurse or a health aide in the room, and they can really help. Like I can say something and they can understand it and help interpret, and make sure that the patient kind of understood the question. I mean, I've seen that come up a lot more with hearing loss than maybe I just don't have that many elderly patients with cognitive impairment that I take care of, but I think it's the same kind of principle. Like if you're doing it clinic to clinic, it could actually be helpful to have that local person help and make sure they understood what you said, make sure they, and then spend a little more time with them after the visit going over it. If you're doing it direct to patient, I could see that being more of an issue because you don't have somebody there to help unless you have a family member there. So that one. And then with respect to lupus, that is actually one of the more common things I see. I just didn't mention it, but did you have a specific question about lupus?
Well, yes, because that I mean certainly can be a more serious disease. So my question was, how is your management of lupus patients going with telehealth? And just from a demographic perspective, we think of lupus and we think of kind of the younger adult African-American female is being like a high-risk demographic. What does it look like in terms of likelihood with the Alaska Native population?
Oh, wow. I feel like they might have planted you here. So I was the lead investigator for the CDC-funded Indian Health Service Lupus Registry. And we actually published together with some of our colleagues in other places in the US, kind of a meta-analysis just recently of lupus epidemiology in American Indian, Alaska Native versus Black, Hispanic, White, Asian in the US. And actually the American Indian, Alaska Native lupus rates in Alaska and lower 48 places that we included is as high as, the prevalence is as high as Black women. So that's one thing to say. The other thing to say is actually, yes, and most common age of onset is women of childbearing age, but then it of course becomes a chronic disease. So, and so as long as they're living, it's still with them. So we do have older patients with lupus as well. The nice thing about telehealth for something complicated like that is the ability to sort of check in more often. A lot of times they might need labs, but maybe our physical exam isn't important for every single visit for a lupus patient, whereas maybe a review of the labs might be more important. And we can get labs in a local clinic and then do a lot of counseling, talking about the disease, what they can do, how they can watch for flares, what they can do to manage it themselves. So I actually think in diseases like lupus or vasculitis, having telehealth as an option really can improve our ability to communicate with people.
Okay, great. Thank you very much.
Thanks.
Oh, Dana, you're muted.
Thank you, Meredith. Thanks, Liz, for that great overview, and I look forward to your updates. We're a little bit short on time, but our next speaker is Dr. Brian McMahon, who also wears two hats at the Alaska Native Tribal Health Consortium. He is a clinical provider for liver disease as well as being a researcher. And so he also travels throughout rural Alaska doing liver disease clinics, and the liver disease and hepatitis program at the Alaska Native Medical Center also uses telemedicine extensively. So Dr. Brian McMahon is going to tell us a little bit about the uses of telehealth in liver disease. And Brian, we are a little bit short on time, so I think you were going to do more of a TED Talk type of thing, but probably if you can limit it to just like 10 minutes, that would be great. So
that's easy for me to do, and thanks for inviting me, Dana. And many of the things that Liz, Dr. Ferucci has mentioned are the things that we would do. But I have to be honest with you, telemedicine is relatively new for our department. We really started it about the time of COVID. We maybe did one telemedicine visit at the most a month prior to COVID. But since then, we have extensively used telemedicine, including in our field trips. So we go out every year for liver clinics to all the different tribal groups that have hospitals, large hospitals or large clinics in Alaska once or twice a year and see patients. And this is the first year where we've actually gone out to places like Sitka or Fairbanks, for example, and instead of them bringing patients in from the smaller communities, we see the patients that live in Fairbanks or live in Sitka, but then the smaller community patients this year, what they did was had us use telemedicine to see those patients because they didn't want them traveling with the COVID pandemic going on. So we would have two uses for telemedicine. The first is the use that we've had for the last year in seeing patients. And telemedicine is most helpful for us in guiding patients who are on medications. So we have a lot of patients that are on medications for hepatitis B or patients that are on medications for autoimmune liver diseases, such as autoimmune hepatitis and primary biliary cholangitis. And we frequently have to make medication changes in those patients if they're not in good control, or if we're tapering their steroids, for example, if they're newly diagnosed with autoimmune hepatitis. And that's something that that worked really well over telemedicine, and we will continue to do that in the future. I think that's one of the biggest, for us, the biggest uses for telemedicine. The second is that we have seen patients that have liver conditions which aren't rarely very serious. They don't need immediate attention. And for those patients, a lot of the telemedicine visit is spent on education. So it's very difficult, unlike patients with, it's a little bit easier with some of the rheumatic disease, especially rheumatoid arthritis. And I'll just tell you my own experience with that just recently when I was in Sitka. With rheumatoid arthritis, for example, you can have the patient, I saw a patient who has autoimmune hepatitis and rheumatoid arthritis because rheumatologic diseases run together in the same patients frequently. So this patient had rheumatoid arthritis, and I was able to have her lift up her hands. I could look at her MCP and her other joints in her hand and see they were swollen, and then I could have her. She had frozen shoulders, so I could have her lift her arm up and see where actually her shoulder went to before she couldn't lift it any higher. And so I can see that in that disease, telemedicine would be something that you could do part of your physical exam over telemedicine. For liver disease, there's really not any way to do a physical exam. If somebody's jaundiced, you can have them bring the camera up to their eyes and see that their eyes are icteric. The other thing you can do is if they have ascites or fluid in their abdomen, you can have them pull up their shirt and you can see that they might have ascites. But other than that, we can't really assess the size of the liver. And one of the really big tools that we use in both at ANMC and also on our field trips is something called FibroScan. So FibroScan is called vibration controlled elastography. And what it does is it's a unit that uses powerful sound waves to shoot through the liver, and it measures the stiffness of the liver, which correlates to the amount of scarring in kilopascals. And there's a lot of data on where the cutoffs are, and we can tell if somebody has no scarring or if they have a lot of scarring, or maybe they have some scarring. And it also measures the amount of fat in their liver, because fatty liver is a very big problem now in the US. As everybody knows, obesity is present in about a third of the US population. It's probably the same with Canada. And about a third of the US population is overweight, and about a third is at ideal weight. So a great proportion of those patients with obesity have non-alcoholic fatty liver disease, which the name is changing to metabolic associated fatty liver disease because it goes along with the metabolic syndrome. It's not related to alcohol use. And what we find is that about a fifth of those patients have a situation where the way that the fats the triglycerides are metabolized creates very toxic, highly oxygenated products, which damage liver cells, bring in white cells, which secrete cytokines, which do more damage, and they could progressively develop cirrhosis. And cirrhosis secondary to non-alcoholic fatty liver disease is the #2 reason for liver transplant. in the US, and it's going to be #1 soon because we're treating a lot of hepatitis C patients, the current #1, which is dropping down. So for those, we really need a FibroScan. We have 2 FibroScan machines, one at ANTHC and a portable one we can shove on the airplane in the overhead bin. So we can't do FibroScan, obviously, over telemedicine. So telemedicine for us has limits clinically, but is useful for certain things such as medication tapering and schedule and changes in medicine. The other thing that we're going to be using telemedicine for a lot, which I think is going to be really unique, is, as many people know, hepatitis C is now curable with direct-acting antiviral oral drugs, which, given for 8 to 12 weeks, have cure rates of over 95%. And they really have no serious side effects at all. A mild headache, mild upset stomach, but nothing that's serious, nothing that requires hospitalization or emergency intervention. And so hepatitis C is prominent all over the world, and in the US, related to the injecting drug epidemic that's going on now. But in the baby boomers like me, it's about 1/3 of them, or a little bit more, got it because we didn't use blood precautions back before HIV was discovered, and people got infected from tattooing, from dentists not properly sterilizing their drills, and from transfusions. They weren't screened, and many other healthcare associated ear piercing wasn't regulated, nor was tattooing. So there were a lot of infections that occurred, and people didn't know that they got infected, because acute hepatitis is usually doesn't occur very often with hepatitis C. So these are people that are developing cirrhosis. They need to be treated. They can be cured. So when they're in the villages, they can't get in the 3 or 4 visits to the local regional center to get all their management. And we feel that we can do this with telemedicine, with the community health aide practitioner, and with the patient. So we have a small grant from the Division of Viral Hepatitis at CDC that we're collaborating with the Arctic Investigation Program and DVH to do a pilot study in 5 villages, where we're going to be screening with a rapid hepatitis C antibody test, and we're going to then treat these patients that are positive with telemedicine and using just the health aides. And the WHO model for hepatitis C is that they want to train people who are not licensed providers to treat hepatitis C. So this is kind of a WHO and Alaska Native model of how we can use telemedicine to do a pilot study. And we've applied for a PCORI grant to expand that to 25 more villages. And that just is going to go in next week. And if we get the PCORI grant, we're going to be off and running. And the idea would be that we have a lot of patients that are in the rural areas with hepatitis C. We know of 184 people that are in small villages that have active infection that aren't being treated, partially because of the COVID travel, but they can't afford, nor can the corporation afford, to send them 4 times in if they don't have Medicaid, for example. And we can get them treated and get them cured if we can set this program up and get it going. So that's kind of what we're looking at. We think telemedicine is going to be really important in treatment of hepatitis C, not only in Alaska, but in other rural parts of the US and parts of the world. So that's our big project for the future for telemedicine. And then we would go out to these villages at some time and do a FibroScan, because we want to know who's got cirrhosis. And if they have cirrhosis, they're going to need monitoring every 6 months with ultrasound and an alpha-fetoprotein, a marker for liver cancer, because their risk of liver cancer could be as high as 3% per year, even if they're cured of hepatitis C. So that's pretty much what I have to say about how we have used telemedicine. What has we found to be the favorable benefits of it, and what we found to be the deficiencies that in telemedicine, especially can't do a physical and can't do a FibroScan. And then what we hope to do with our big project with telemedicine coming up, which I think to me is really exciting and could be something that could be expanded throughout IHS throughout Alaska and other areas, Canada and other areas for people who are living in remote regions. So I'll take any questions now or comments that we have. And did I do okay, Dana, for my time?
You did great. Thank you for
Oh,
that
you're welcome.
synopsis. It's
I'm
very
sorry I had so much time getting on the site. I worked for about 10, 15 minutes to get on and finally was able to get on. So I think I see Catherine you have has a question. Yes.
Thank you so much for your talk. I don't know if you were on when I was asking Liz some questions, but I'm a pathologist and transfusion medicine physician, did my fellowship at Georgetown University Hospital, which is a big liver transplant center. So my feeling or supposition would be, if you need a liver transplant and you're in Alaska, particularly in these rural areas, that's tough to manage. Do you do transplants anywhere in Alaska, or if someone in one of these smaller villages gets to a point either with untreated Hep C or autoimmune hepatitis or PBC, PSC, whatever, and they need transplant, what does that look like?
So we don't do them in Alaska, but we have an agreement with University of Washington, which is one of the stronger transplant centers in the Pacific Northwest. And we have a lot of patients we send down for evaluation, and we've had a lot of patients that have been transplanted for a variety of conditions. The challenges, I think, are managing them prior to the transplant, we can use a MELD score to follow them along by having the community health practitioner draw blood and send it in to us, and we can calculate MELD. I think telemedicine will be helpful in us in the villages now in interviewing them to see if they're good transplant candidate. I think that to be a candidate for transplant, there's a lot of things that you have to meet, which is strong support from household members or somebody else that can come with you when you go. The history of alcohol is really important. Alcohol rehab, that's a tough one in some of the communities where they don't have any, they don't have a behavioral health person that can counsel the patient. But I think that's something that we'll be doing more of in the future, using telehealth. The other thing would be is monitoring their post-transplant immunosuppression. And I think there's a role for telehealth in that too. And counseling them and telling them the importance of taking their medication and getting their blood draws for looking for side effects, or looking for with tacrolimus, for example, looking for the tacrolimus levels that would be effective. So I think everybody has an equal shot in Alaska as any place else to get a transplant. It's just that that's done in Seattle, and the logistics are more difficult. But we seem to do okay, I think, with that. So.
Great, thank you very much.
I think there's something in the chat box. I don't see if I can figure out what it is. It was just about the connection.
Yeah.
Okay.
I think we're good.
Okay.
I think we're a little short on time, so I do have a lot of questions, but I think I will save them. But thank you both for those great summaries, and I just look forward to seeing what happens post-pandemic in your studies, Dr. Farrucci, and then with Brian, it's super exciting that telehealth is going to be a part of treating people with hepatitis C out in rural Alaska. So do we have any sort of closing things that we need to do, Meredith, or?
No, I don't think so. I think we can let everyone go and give everyone 4 minutes.
Okay. All right. Well, thank you both for joining us today. And this will be this webinar will be posted on the IARPIC website, so available to others. So thank you all.
Thank you for
Bye now.
Bye-bye.
Thanks, Dana.